regards to the question about the Valsalva maneuver and the bilateral numbness tingling, some of the things the original poster talked about was looking at things like levels like segmental rotation, extension, I believe, some of the things, and was mentioning some things were DN, dysfunctional, non-painful. So it sounds like he's taken at least SFMA level 1. And so one of the things that I had mentioned was maybe intra-abdominal pressure. So kind of looking at the core, thinking it as a cylinder. So you want 360-degree kind of pressure equal to everywhere, pushing out. And I really like to blend SFMA and DNS, Dynamic Neuromuscular Stabilization, intra-abdominal pressure for this. In particular, I really like the SFMA's assessment of the ribcage. So if you've taken level 2 somewhat recently at least, hopefully they kind of went over their ribcage assessment. So normally I do, and I wanted to show you that first because I found teaching intra-abdominal pressure is way more successful if there's enough room, mobility in the ribcage and thoracic spine. So that's where I kind of wanted to start off first, just to make sure people watching this video know how to assess the ribcage and thoracic. So when assessing ribcage mobility, you have patients on their back, knees bent, so they're in hook line position, and just kind of looking at what's the resting posture. Is the ribcage really flared? Looking at the intercostal angle, is it really wide, really narrow? Looking, it should be about 90 degrees. And then kind of just doing this kind of global assessments, kind of like the lower quadrant. So kind of pressing, does it move or not? And then doing the same thing kind of from the front or from the top superior quadrant. So you're pressing, how do those move? Hopefully they both move. And then also looking at diagonals. So left, like upper quadrant, right lower quadrant, up right upper quadrant, left lower quadrant. And I've found oftentimes that individual quadrant assessment moves fine. When you go into the diagonals, or also kind of, I call it like the cylinder, so you kind of assess left upper quadrant and left lower quadrant. If you find some stiffness there, there's often some soft tissue restriction in the rib cage. And then I kind of turn them onto their stomach and kind of assess rib play, kind of looking superior, inferior, medial and lateral, and seeing, is it stiff everywhere or just like in one direction, or maybe not even. And then I like to do sideline, put like a pillow or something under, so they kind of side bent over, and then kind of here taking deep breaths and kind of moving up the spine on either side. And I find that it really opens up the rib cage and thoracic spine. So now if you've gotten the rib cage moving, thoracic spine moving, then you can start to look at the intra-abdominal pressure. Basically, the idea is you want to set your patient up to be successful, right? You need to have good rib cage mobility and be able to place the rib cage appropriately in order for the diaphragm and everything else to work in the ideal manner. So I have found that things are a lot more successful when you do that versus, before I was doing this, there was a lot more struggle with getting patients to kind of really understand and do the intra-abdominal pressure appropriately. And I think a lot of that was just, there was too much stiffness that they were trying to fight in the rib cage, so they weren't successful. So one of the areas that are most common issues are kind of like the posterior lateral wall area. People have a really hard time kind of feeling that one. And so one thing that I really like is you're just going to go into this position here, and if I wanted to work the left posterior lateral wall, I'm going to push my right foot into the wall. So I'm going into right hip extension, and that will get the left posterior lateral quadrant engaged. I can try to increase it more by doing some resisted hip flexion. That gets kind of my front going a little bit more. of really trying to feel that, and then switch, kind of pushing that left one in, feel that right, posterior lateral wall engage. Try to increase things more by doing some resisted left or right flexion. And then the other one is the lower abdominal wall, kind of where most people's pant line is. That one also seems to be a struggle for people as well. So that can often be helped with that resisted hip flexion, kind of palpating, and then also just kind of really think of, if you breathe in, kind of push out below the belly button. I'll often kind of be feeling, and I want to feel tension under the fingers, sometimes getting some like tapping pumps. For those who really struggle, sometimes it's more take a deep breath in and then have them hold their breath, and then kind of work on it and find it, because sometimes they have a hard time coordinating the breath and the activation that we're looking for. So if they hold their breath, they do a much better job of feeling it. And I kind of have them work on that until that becomes a little bit easier. And then they'll often then struggle as they breathe out to maintain it. They just kind of let everything go. So it might be breathe in, hold it for a little bit, make sure you got it. And then I'll tell them to slowly breathe out through like pursed lips. And make sure they're feeling. And then if they feel like they've lost that contraction, I tell them that I want you to stop. Breathe back in a little bit, reestablish that intra-abdominal pressure, and then continue the breath. Just kind of progressively working into more and more exhalation. And so that's kind of some basics that I like to do, working some intra-abdominal pressure.